Dead space is ventilation that does not participate in gas exchange. So anatomical dead space is fixed, it's not changeable, versus alveolar dead space is the dead space that reflects a non-functional alveoli. So this can change over time. Anatomical dead space is just the air that remains in our passageways, our conducting passageways of the lungs. So it's the air that's like on our way to the alveoli but hasn't gotten there yet. Versus the alveolar dead space is how many alveoli are non-functional at a given time. Total dead space is these two combined together then, and that effect directly can affect our efficiency of ventilation. Looking at physiologic dead space, it increases when alveoli are ventilated but not perfused. So again, this commonly occurs in pulmonary embolism and advanced lung disease. So we have our anatomic dead space. This is we can't change. And then we have our physiologic dead space, so the dead space that can be adjusted. And that's the space where the alveoli become ventilated, but they're not perfusing. They're not actually exchanging gas exchange on either end. And this is kind of showing our volume, our dead space volume as a whole. So with pulmonary function testing, we can use spirometry and we can interpret this clinically and come up with stuff, with explanations for what's going on. Patterns of abnormalities and allow differentiation between obstructive and restrictive diseases. Spirometry can distinguish between an obstructive pulmonary disease, which we see increases resistance and air trapping, often increasing our total lung capacity and our residual volume because of hyperinflation. And it can distinguish that from a restrictive disease, which limits expansion and that will reduce all lung volumes. Our pulmonary function test can measure the rate of gas movement. Two values are kind of key here. FVC, or forced vital capacity, reflects total exhalable volume, the amount of gas that you forcefully expel or exhale after taking a deep breath in. You take a deep breath in and you blow it out as fast as you can, total amount that you are able to do. Versus forced expiratory volume is reflecting more airway resistance. It's the amount of gas expelled during a specific time interval of your forced vital capacity. So typically one is the first second. Healthy people, healthy individuals can expel 80% of their forced vital capacity in 1 second. Patients that have an obstructive disease often exhale less than 80%. Patients with a restrictive disease can have normal, or sometimes they can even exhale more. Alveolar ventilation, which is different than minute ventilation, determines carbon dioxide removal. It accounts for dead space and tidal volume and is the most meaningful measure of effective ventilation. Minute ventilation measures the total airflow per minute, but does not distinguish effective from wasted ventilation. So high minute ventilation does not actually indicate that we're getting good gas exchange per se. And then minute respiratory volume is just uh, our tidal volume times our respiratory rate. Our alveolar ventilation rate, on the other hand, shows why increasing tidal volume is more effective than increasing our respiratory rate for improving alveolar ventilation. Rapid shallow breathing is actually inefficient. And this is just showing in and out, gas flow in and out of alveoli during a particular time. It's a better indicator of effective ventilation. It takes dead space into account, tidal volume, as well as rate of breathing. And because dead space in an individual is normally constant, our alveolar ventilation is affected by tidal volume and frequency. So significant increases in AVR are brought about by increasing tidal volume, our breathing amount, versus our frequency. So rapid shallow breathing could actually decrease our total alveolar ventilation rate. How do we put all this together? Lots of numbers, lots of names. This is showing kind of a integration of mechanics, pressures, resistance, and compliance and measurements. And ventilation is showing a balance between physical forces and biological control. So it's kind of showing at normal rate and depth of breathing, our dead space volume is going to remain constant. Our tidal volume is around 500 mils. If respiratory rate is about 20 breaths per minute, which is average but high average, it shows minute ventilation is going to be the same. We've made it so it's all the same for all these values. And then alveolar ventilation rate we can see here is 7,000. And so this is effective ventilation of 70%. So this is like baseline versus if we did slow deep versus rapid shallow. If we did slow deep breathing, we're going to have a lower respiratory rate, a higher tidal volume, versus if we did rapid shallow breathing, we're going to have a higher respiratory rate, but a lesser tidal volume. Our minute ventilation rate is still the same because these all still map out to 10,000. But our alveolar ventilation, taking into account our dead space, is going to be much greater, 85% effective if we take slow, deep breaths versus if we take rapid, shallow breaths. Ultimately, I hope this was helpful in kind of going through some of our different ventilation factors and components that can help tie in ventilation mechanics. We'll continue to discuss these different components as we move forward in our respiratory slides and lectures, but this should get you started and be able to understand how we can apply some of these theoretical concepts more clinically.